My name is James Brink from Yale University School of Medicine, and today I'll be speaking about the benefits and the responsibilities of computed tomography. I'd like to begin by acknowledging the contributions of my vice chair, Dr. Rob Goodman, who joined us from the UK several years ago. And Rob has a very interesting perspective about radiation control, and I think it will be helpful to understand that perspective, giving us a sense of what transpires in Europe, as well as to compare that to what goes on in the US. Certainly the benefits of computed tomography are well known to us all. The superb anatomic depiction provided by computed tomography allows innumerable diagnoses to be both confirmed and excluded on a minute-by-minute basis worldwide. It really is a phenomenal resource to us as medical practitioners. And many of the cases I'm going to show you now really highlight, I think, those benefits just intuitively. Knowing the ability to see pathology and see it with the clarity as depicted with computed tomography is of great benefit. For many years, we enjoyed the benefit, and continue to do so, of so-called breadloaf slices of the body. Two-dimensional transaxial images were the mainstay with which computed tomography contributed to our understanding of the human anatomy. In a case such as this, which illustrates a hepatoma arising from the left lobe of the liver and invading the stomach, of course, requires a good bit of training to understand what one is seeing with these breadloaf slices, but the detail and clarity with which the anatomy is depicted was exquisite and remains just an important contribution to many, many medical and surgical conditions. And with that benefit, of course, came the possibility, once we've developed better and better scanners, of imaging in different planes, of being able to image in the coronal plane, the sagittal plane. And this case highlights that benefit by taking this very dilated bowel that's seen on transaxial images, and when reformatted in the coronal plane, we can identify, in fact, the bird's beak indicative of a sigmoid volvulus, and make a very specific diagnosis, really facilitated by imaging and reconstructing images in planes other than those that were acquired originally, namely the transaxial plane, again reformatted to other planes. The benefits of multi-slice imaging then become even more compelling when we consider marrying those technologies with some of the newer technologies that have been made available through the gaming industry. New, quote, new uses of computed tomography begin with, for example, replacing the intravenous pyelogram with a CT scan without IV contrast to depict renal or ureteral calculi. But then combining these multi-slice images with volume rendering techniques, again made popular in the gaming industry, to allow us to produce virtual fly-throughs, if you will, of the colon. Virtual depictions of the blood vessels of almost every anatomic region or vascular territory, including the head, pulmonary vessels, aorta, and extremities, and of course the heart as well with the coronary arteries. Beginning just with renal calculi, this was a huge benefit of CT, to be able to really take us beyond the need for IV contrast and the very prolonged delays in depicting renal calculi and ureteral calculi. To do so simply with a non-contrast CT scan is quite remarkable. This case shows not just the stone impacted at the left ureterovesical junction, but also the swelling and the edema within the trigone of the bladder resulting from that impacted stone. Turning to the colon, the ability to replace the conventional colonoscopy examination with a virtual colonography exam produces images that really are remarkable. You can see the polyp here in the left lower quadrant of this image, rendered virtually from these transaxial and reformatted coronal and sagittal images of the colon, giving us the ability to fly through that colon. Not only can we fly through it, but we can color code mucosa that we haven't seen flying one direction with a different color flying the other direction, as is provided by this short video from Perry Picard. In tangerine is the mucosa that wasn't seen when we flew from the other direction through the colon, but now visible as sort of the mist patches of colon mucosa that were visible on a retrograde fly-through. And of course, the ability to render the blood vessels is exquisite. Here's a case of a patient who's had a traumatic fracture dislocation at C4-5 on the, C5-6, I should say. I'm sorry, C4-5 on the left, with occlusion of the vertebral artery on that side and reconstitution of that vessel at about C2, as compared to the opposite side on the right, in which we see the vertebral artery throughout its entire course in the intervertebral foramina and normal alignment of the cervical spine. Here's another patient with who's suffered a motorcycle accident and a comminuted fracture of both the tibia and fibula, with a question of an arterial injury across that fracture site. Very unfortunate accident. And you can see with CT angiography we can easily depict the occluded left anterior tibial artery with reconstitution below the fracture site. And of course, leveraging the very strong negative predictive value of CT with in the coronary arteries. Here's a patient who's had stents placed in his coronary arteries, he suffered acute chest pain. And when we see the blood vessels nicely filled with contrast the coronary arteries, we can leverage that high negative predictive value to know that coronary artery disease is unlikely to be the cause of this patient's chest pain. And our ability to identify plaque is, of course, both soft and hard plaque is another potential benefit of this technology, perhaps not with the same level of diagnostic confidence as with the negative studies, but still important to be able to depict that and then compare it to a direct-based catheter angiogram. Here we're color coding both soft and hard plaque, the hard plaque in blue and the soft plaque in yellow. Another patient with diffuse plaque in the proximal LAD, when we color code that plaque, we can highlight both the soft and hard plaque throughout the course of the LAD. All made possible with simple transaxial images, the same technology that I showed you at the beginning, the Breadloaf slices, with advances in technology that allow gating and very high resolution imaging to produce this kind of depiction of very complex anatomy. In addition, we can leverage the high temporal resolution to permit us to evaluate 3 possible causes of chest pain: aortic dissection, a pulmonary embolus, and coronary artery disease, all with the same bolus of contrast in appropriate clinical settings. A really amazing opportunity to rule out these 3 diagnoses with a single bolus in just a few seconds. And when we do have positive findings, of course, being able to render them with volume rendering as well as in oblique coronal reformations. For example, this type B dissection of the descending aorta, nicely depicted with a 2D representation on the right and a volumetric representation on the left. Pulmonary emboli, nicely depicted, easily seen as filling defects within the pulmonary arteries, both on transaxial and oblique coronal reformations. Now, this benefit, it really gets us all very excited, and it really led to a real technology explosion. But with that comes some responsibility. And that responsibility is to recognize that the radiation dose associated with these technologies can be problematic. And I think this video highlights, I think, kind of where we were 9 or 10 years ago in our thinking, being very excited about the possibility of performing a simultaneous evaluation of this patient with a FDG avid colon cancer in the left colon, seen on this PET CT, then fused with a CT colonography study, and then fused with a CT angiogram, all depicting this same colon cancer. The point being is that these 4 doses of radiation, PET, anatomic correlate CT, CT colon, and CT angio, were probably over and above what is needed to serve this patient well. And certainly our thinking has evolved since this point in time to be much more cognizant of the amount of radiation we're giving for routine diagnostic procedures. Which brings us to probably the most important principle then, which when it comes to the responsibilities we have, is to recognize that with the marked rise in the volume of CT studies that we are able to perform and the complexity of the exams that we're able to perform, then we have to acknowledge the fact that the collective dose to the population is rising from that, and has been rising exponentially up until recently. It's owing to many factors: the higher radiation dose per exam compared to a plain radiograph that it might have replaced, an increasing number of indications, the increased availability, the speed and ease of use, all have really led to this acceleration in the use of computed tomography. And that is mirrored by the increased number of exams that were seen from the early 80s to the mid 2000s, really rising up to 60, 70 million exams and beyond where we are, which is where we are today. Certainly utilization has tailed off with the concern about radiation in the most recent years, but there really was a marked explosion over that 20 to 30 year period since CT was first invented. This article in USA Today, I think, highlights some of the challenge that we have in managing the benefits of CT and being responsible for its use appropriately. And it really came out in 2007 when individuals became concerned about unnecessary CT scans that might be exposing patients to excessive radiation. And the statement that got everyone most concerned was this one: about 1/3 of all CT scans that are done right now are medically necessary, said the lead author of this particular study in the New England Journal. But to me, it really is a call to action, meaning that our greatest responsibility, I think, is not just in managing the techniques that we use to keep the dose as low as possible, but perhaps with an even greater impact is to make sure that we're utilizing it, this wonderful modality, most judiciously and appropriately. And so appropriate utilization, the steps that we can take to control utilization really relate to three key principles. The first is to make sure that we're utilizing each test in a way that is most appropriate for the patient and his or her clinical application, to tailor the exam to that patient and application with the intent to reduce dose as much as possible. But also we have to be recognizing when CT is the appropriate test as compared to other imaging tests that may not use ionizing radiation, such as ultrasound and MRI, and to avoid unnecessary and repetitive studies that are being performed sort of as a standing order, if you will, without contributing to medical care to the degree that each individual test should. So let's really focus on, at the moment, CT versus other imaging tests. And what can we rely on to help us to be responsible in choosing CT when it is most appropriate? And the answer that I'm going to give you are what many around the world refer to as referral guidelines. And here in the US, we refer to as appropriateness criteria. These are, in the US, really pioneered by the American College of Radiology, and they represent a large database of clinical scenarios and imaging tests that are then assigned a particular appropriateness criteria score. The idea being that a score of 9 is the most appropriate, 7, 8, or 9 is appropriate, 4, 5, and 6 are sort of in between, and 1, 2, and 3 would be relatively inappropriate. So the way this works, it's a big database of clinical topics such as hematemesis, variants such as no history of alcoholism or liver disease, and then many different possible imaging tests that one might consider with appropriateness criteria scores as shown. When I surveyed the appropriateness criteria database a couple of years ago, there were 167 topics, over 800 variants, for a combination of about 7,500 topics, variants, and tests. And the first conclusion I reached from doing this exercise was a bit surprising to me, was how often is CT listed as a possible test? And CT was listed only in 931 of 7,500 combinations, or about 12%. And certainly the amount of CT that we do leads us to think it's probably more often than that 12%. But that was the first thing to note, is that it's really only listed as a possible test in 12% of those combinations. Now, rather than displaying this in an Excel spreadsheet as I just showed you, it's actually available on the web, and I encourage you all to look at the ACR appropriateness criteria. It can be very informative. Suffice it to say that this is the type of display that you will see on the web, and you'll note with the same combination of hematemesis, no history of alcoholism or liver disease, the same test laid out. It shows that, in fact, CT is only a score of 4, which would not be nearly as appropriate as some other imaging tests. Note that it also gives a relative radiation level, in this case showing a sort of a medium exposure, and it gives there's a guide to show you kind of the range of exposures that correlate with the level of exposure that's available through the the appropriateness criteria website. If we look at a different condition, blunt abdominal trauma in an unstable patient, you see that, again, CT is not the most appropriate test. It's listed as a 7 with plain radiography and a fast ultrasound exam scoring higher in appropriateness as compared to a patient who's had blunt abdominal trauma who is stable with hematuria. Then CT is the most appropriate test. And so you can see how you can leverage the appropriateness criteria to help you understand the relative priority of tests, one versus another, those that administer ionizing radiation versus those that don't, and help communicate that to your referring physicians. Now, it's interesting to see that, again, even without hematuria, CT is the most appropriate test. And in summary, CT is listed as a 7, 8, or 9, meaning among the more appropriate tests about a third of the time in 285 out of the 931 scenarios in which CT was a possibility. And CT was listed as the number one, the highest or most appropriate test with a score of 9 in 115, or 12%. So about 12% is an interesting number. First, 12% of all combinations included CT, and of those, 12% had CT as the most appropriate test with a score of 9. And so another key axiom that I think is important for us to keep in mind when we're being responsible to leverage those benefits of CT is that in high-risk patients, CT should be avoided when an ultrasound or MRI is of comparable diagnostic utility. And here I think there's no better example than women who are pregnant with right lower quadrant pain. Here at our institution, we do not perform CT. We performed MRI without IV contrast material. And you can see that, as in this example, the dilated appendix filled with low signal appendicoliths is easily depicted, and a wonderful test, very simple to perform, simple 2-2 weighted imaging without IV contrast gives us this clear depiction of appendicitis. In addition, confounding diagnoses that might be present in this population include renal calculi, and even those can be identified, such as in this case, this low signal stone seen in the distal third of the right ureter, just at the pelvic brim, resulting in pilosinus backflow around the renal pelvis up at the kidney. The same kind of detail that one might have acquired simply, but without the use of ionizing radiation that would have been associated with a computed tomography study. And if we turn to the appropriateness criteria for this condition, namely right lower quadrant pain in pregnant women with fever and leukocytosis, you see that CT is not the most appropriate test. It shows that ultrasound of the right lower quadrant or MRI of the abdomen and pelvis without IV contrast are more appropriate than CT for this clinical scenario. So again, in these high-risk individuals, we really want to be looking for the opportunity, when at all possible, to leverage the non-ionizing radiation producing modalities of ultrasound or MRI. Asymptomatic patients also pose an interesting question to us when we try and weigh benefits versus risks. And this was an interesting paper by David Brenner in gastroenterology some years ago, looking at CT colonography. And Dr. Brenner pointed out that the American Cancer Society endorsed a CTC as a screening test for colorectal cancer. The anticipated lifetime risk of colorectal cancer is only about 5 to 6%. There's a potential risk of radiation-induced cancers from CTC that he estimated at 0.14% for 50-year-olds and 0.07% at 70-year-olds, clearly showing that the benefit of 5 to 6% greatly outweighs the risk, and thus screening with CTC would be appropriate. So the same kind of analogy and analysis can be applied in the screening population as well. Let's turn now to the final axiom that we want to consider when it comes to being responsible about the utilization of computed tomography, and that is to avoid unnecessary or repetitive studies. I show you now a quote that I received once in trying to counsel one of our emergency room physicians about the need to be cognizant about repetitive studies, and the answer I got back was, I am an adult and a physician. I don't need your approval for CT scans that are necessary for my patients. And clearly that is the pushback that we receive sometimes, because the emergency medicine physicians are under tremendous pressure to speed throughput through the emergency room. And we get caught in this yin and yang between increased throughput versus taking the opportunity to take a time out and think about what is the most appropriate test that we need to do. Certainly this has been a major effort of many institutions and organizations. The National Council for Radiation Protection took this on a few years ago by convening a consensus conference including emergency medicine physicians and radiologists to reach some consensus. Their first paper was published in 2011 in JACR, but a lot more work is needed to come to consensus on the appropriate use of CT in the emergency room. Physician education is critical, and this is a study from some years ago in which we surveyed practitioners in the emergency room about the most appropriate tests to be performed, and more importantly, the radiation dose associated with those tests. And you can see that individuals who were questioned about the radiation dose associated with abdominal CT didn't do so well. You can see that the correct answer was, but the question was how many chest X-ray equivalents were being imparted with a abdominal CT scan. The answer was in the range of 100 to 250, but most of the individuals, both among the referring physicians, even the radiologists and the patients, thought it was in the range of 1 to 10. Hopefully if we repeated that study today, many years later, at least the radiologists would do better, because we've certainly heightened awareness through many campaigns to educate the practitioners involved. But suffice it to say that physician education is absolutely critical. Certainly in the UK and in Europe, there's a very different approach to this, because for many years they've been under a much more pressure to adhere to appropriate justification criteria and referral guidelines for using CT. The ionizing radiation medical exposures regulations in the UK were I should say in Europe, were a result of the directive from the Council for the European Union, and these were developed. The IRMR was developed by the UK in response to that directive, such that it really forms a legal requirement for practitioners to adhere to these guidelines, something that isn't so stringently applied in the US. Another axiom is that CT should be avoided when the benefit is marginal. And here I think one of the key examples comes in the setting of renal colic, when CT is performed in patients with flank pain. We looked at this some years ago too, about how often this is happening in our emergency room. We found 4,500 patients received 5,500 exams over a 6-year period for flank pain. The mean age was 45, and disturbingly 4% of these were in children. You can see that many patients had 3, 4, 5, 8, 10, 15, even 18 flank pain CTs in this period of time. And that with those with a cumulative number of CTs amounting to 15 or 18 reached significant exposure levels cumulatively exceeding the 150 millisievert threshold that defines the lower limit or the upper limit for low-dose exposure at the atomic bomb blast. So it's critical that we really pay attention to these repetitive CT scans to make sure that they really are affording the same benefit as the single initial scan, when in fact perhaps a plain film or a follow-up ultrasound could have had a similar benefit. It highlights the fact that the practice of radiology really is highly variable across the country. It highlights the need for us to standardize our practices and processes among institutions across the country. We need multidisciplinary diagnostic algorithms that go beyond these appropriateness criteria that help really guide practitioners to the right imaging tests. This was highlighted to me a couple of years ago when the New York Times did a story on the frequency with which institutions performed so-called double CT scans of the thorax, meaning scans with and without IV contrast, when most of the time one needs either with or without, but not both. And it showed that 200 hospitals did with and without scans more than 30% of the time, the national average being 5.4%. Massachusetts had the lowest utilization at 1%, ranging all the way up to 13% in Oklahoma. And poor Ludington, Michigan, an institution there, did double scanning 89% of the time. Best practice is certainly less than 5% and possibly even less than 1%. If you look at this map of the US, you see the wide variation in practice patterns. Interesting how the high utilization rates cluster in certain geographic areas. San Diego, California, Chicago, Illinois. I think that's Tampa, Florida down there. But it really highlights the fact that I think in some of our communities, the practice tends to be fairly regional rather than really nationally adopted, and we need to do a better job of standardizing our processes across the nation. Diagnostic algorithms are, I think, the way to go. They're very difficult to come by. This is one that we developed at Yale. It's too complicated, an algorithm to help us guide practitioners to the appropriate workup in patients with suspected pulmonary embolism. I give big credit to the Western Australians who developed much simpler algorithms for many common conditions, and this is, I think, the direction we need to go in the US as well. Note that the Australian algorithms were endorsed not just by radiologists but by general practitioners, and it's this kind of interdisciplinary cooperation and collaboration that will help get us to a higher level in when it comes to appropriate utilization, because it's a two-way street. Ordering physicians need to buy into the concepts that are espoused in these algorithms, and radiologists need to help define them as well. Certainly the American College of Radiology has been helping in this regard. A very important paper appeared in 2010, which is managing incidental findings on abdominal CT for incidental findings in the liver, pancreas, kidney, and adrenal. And this committee is now working on many other organ systems and clinical conditions with a similar type of report that will be forthcoming shortly. But the beauty of this report comes in the form of these algorithms which show what to do when you find an incidental finding, an incidental adrenal mass, for example. Should you always recommend a CT scan? What are the appropriate non-ionizing modalities that one might consider, or is imaging even needed? So I think these are a big step forward, and I would encourage you all to review this very important paper and look for its successor with these other organs and clinical conditions. And so in conclusion, the steps I think to be responsible to leverage the benefits of CT really focus primarily on utilization, to tailor the exam to the patient and application as much as possible, to use CT only when it's the most appropriate test, and other non-ionizing modalities will not suffice, and to really avoid unnecessary and repetitive studies for fear that the diagnostic yield doesn't leverage that benefit nearly as much as a well thought out single test might have initially. Thank you very much for your time.